Hello everyone, I'm Lisa Smoker, and my topic for the final paper is on emerging innovations for the management of atrial fibrillation, or AFib, as it's also known. I plan to discuss some of the new innovative advancements in pharmacology, medical devices, informatics, and also biotechnology. So I chose this topic for several reasons. One, I am a cardiology nurse, as a lot of you know. And so I've worked in the field of electrophysiology for probably about 7 years of those 10 years, but I've worked with cardiology patients for 10. And so it's very interesting to me to see the new innovations that are headed our way. AFib is also a very important topic because it is actually the most prevalent type of arrhythmia, and it affects millions of Americans, and that number is growing each year with the aging population. AFib can also lead to other health issues such as heart attack, heart failure, kidney disease, and embolic stroke, which is the biggest risk factor that's associated with atrial fibrillation. It leads to about 750,000 hospitalizations and 130,000 deaths per year. So I'm going to start by explaining a little about the physiological process of atrial fibrillation, and I'm going to give a historical reflection on the progression of innovations that have led us to up to the technologies that we use today. I'll explain some of the emerging technologies and from each of the realms that I discussed above, and I'll finally give you a brief conclusion. So for those of you that don't have a medical background, atrial fibrillation is an irregular and typically fast heart rate. It involves the two upper chambers of the heart called the atria, which beat erratically and out of coordination with the lower chambers of the heart. It's a result of chaotic electrical impulses that cause the upper chambers to quiver. And I do have a little picture here. You can see the normal heart and the heart with atrial fibrillation, and you can see the extra electrical impulses affecting the heart on your right hand side. And unfortunately, because of these extra impulses, it causes the heart to pump ineffectively and leads to the body receiving less oxygen, and it also actually decreases or slows down the flow of blood through the heart, causing clots, which can lead to stroke. Some of the symptoms patients develop with atrial fibrillation is shortness of breath, weakness, fatigue, sometimes chest pain, or they may be asymptomatic, which is quite dangerous because sometimes patients will come in and have already had a stroke, not knowing they were in atrial fibrillation. So electrophysiology started with the invention of the electrocardiogram by Einthoven in 1903. The first cardioversion was conducted by Lown and colleagues in 1962 on a patient with atrial fibrillation. And in the 1970s is when clinical EP came about, when responses to pacing were interpreted by electrodes placed in the heart. It wasn't until the 1980s that antiarrhythmic drugs were approved by the FDA. Some of them, such as Sotalol and amiodarone, you may be familiar with if you work in the medical field. And these drugs, actually, a lot of them were approved for were not originally approved for atrial fibrillation, but were approved for other arrhythmias, and later approved for atrial fibrillation. So a lot of times we still actually use these drugs quite frequently in our atrial fibrillation patients. Unfortunately, they have poor long-term outcomes as patients oftentimes relapse. In the 1990s, multiple clinical trials were published emphasizing the need for warfarin therapy to prevent strokes in patients with AFib. So it was only in the 90s that we started using anticoagulants, which is quite scary considering AFib, frequently can cause strokes. In 1998, the first radiofrequency ablation with mapping techniques was proposed by Haziger, which was the first curative treatment for atrial fibrillation. And in 2010, the FDA approved the first cardiac cryoablation catheter. So some of the emerging technologies that we see in pharmacology are the non-vitamin K antagonist anticoagulant, such as the rivaroxaban, apixaban, and dabigatran. Edoxaban, with an E, edoxaban, is the newest NOAC approved by the FDA, and that was approved in 2015. And these drugs are similar to warfarin in that they prevent clot formation. However, they're quickly replacing warfarin. Reasons are because there's no monitoring by blood draws involved in patients taking NOACs. There's set dosing regimens. There's lower risk for brain bleed or hemorrhage, and there's no diet restrictions with the NOACs as opposed to warfarin. So for convenience reasons, it's a benefit to patients to take these. Unfortunately, disadvantage of the NOACs is that they're incredibly costly, and a lot of times patients can't afford them because there's not yet a generic version. As far as medical devices, there has been many that have just been recently approved by the FDA, including the Watchman. There's also a new laser balloon catheter, which I'm going to discuss in a little bit, and also 3D mapping, or firm mapping is what it's called. So quite a few things up and coming. The laser catheter, laser balloon catheter, which I have a picture of here. Let me find it here. Looks like this. And it is the newest pulmonary vein isolation treatment for atrial fibrillation. Research has shown that atrial fibrillation typically originates around the pulmonary veins. So the energy is applied by this laser to that area around the pulmonary veins, and lesions are formed, which blocks those extra electrical signals and prevents or eliminates atrial fibrillation altogether. In a clinical study, when compared to the cryoballoon catheter procedure, which is the one I had explained, came out in 2010, it's been found that this laser treatment has decreased the reoccurrence of AFib by 10%, which is a lot better than the cryoballoon. So the benefits of this procedure is that it can result in patients stopping their antiarrhythmic as well as their anticoagulant drugs. The downfall is that the procedure is not 100% curative. They're thinking closer to around 70% curative. So there hasn't been any FDA-approved innovations in the field of biotechnology. However, it's worth mentioning because many studies have pinpointed genetic targets for the treatment of atrial fibrillation. For example, gene therapy studies on animals have shown that there has been conduction velocity reduction, preventing the reoccurring atrial fibrillation in animals, and there's also been studies that have shown disruptions in atrial fibrillation. So there is, things that are being done in the field of genetics where they see that it is having an impact on AFib. Unfortunately, there is no evidence supporting long-term effects of this gene therapy, and up to this point it has only been done on animals, not humans. So the implementation of the EMR to the field of health informatics has greatly improved the quality of care for patients with atrial fibrillation. It's provided many benefits, such as improved multidisciplinary collaboration between physicians. It's provided target samples for research from multiple cohorts, which has improved generalizability in research. It's also prevented adverse events from happening in patients with AFib, for example, like a physician forgetting to prescribe a NOAC. And it's also administered tailored order sets, again, which helps eliminate mistakes and errors. So innovations in the areas of pharmaceuticals, medical devices, and health informatics have greatly improved outcomes in patients with atrial fibrillation. And however, there is more work that needs to be done to find a cure for AFib and improve morbidity and mortality rates. So that's it for my topic, and I thank you for listening, and I hope you've learned something. Thank you.